you, Dr. Swetha, and good morning to everyone here. I'm going to discuss something about the Brooks membrane opening, mainly the minimum rim width, step-by-step approach. Of course, we have this, the Garvey-Heath grid analysis, how we can do that, and also the Hood report. I am Dr. SATHYAN Parthasarathhy from Coimbatore. So when you take the OCT, we have two areas of interest. One is the optic disc, and we have the ganglion cell layer. These are the two areas of our interest. I'm going to talk only about this, the neuroretinal rim, the minimum rim width. Of course, we all need to have a very systematic approach when we are looking at the OCT. That is the rim, then you have to look at the RNFL, and then we have to look at the GCL map. So I'm just going to discuss only about this minimum rim width here. So one, of course, there are about 24 radial scans, and there are about 48 Brooks membrane opening points, which Dr. Sachin was describing. So let's look at this minimum rim width and what is all this the Garvey-Heath grid analysis is all about. So this is basically a 6-sector Garvey-Heath grid is aligned with the anatomic positioning system, which will be described by Prasanna a little later. So the grid is basically optimized for the GCL arrangement. So we'll probably the subsequent speakers can show you that the GCL mapping. So how we really look at that in a clinical way is the printout comes like this. Most of us are used to the printouts, but what we do in our OPD is mostly looking at the screen directly from the machine. That is the best way that you can really see. But this is another way that how you can really see the printouts, but we'll just go step by step. When you see in the machine, this is how you see that. There are 4 zones will be seen. We'll just take you through that. So this is the first area, what Sachin was describing earlier. You have to look at the Brooks membrane opening point and also whether the minimum rim width area is marked properly. That is the yellow marking. If it is not correct, then whatever the scan you have done is not going to be useful, and readings are going to be completely a waste. So make sure that all the 9 quadrants have been taken care first. Then the second area is the B-scan picture to show that how regular the line is. You can see a green line, then you can see the black line. The black line is the actual thickness of the Brooks membrane, not the Brooks membrane, the minimum rim width. So that is the second area. But if you have any problems, of course you have to see the ILM marking. If the ILM marking is wrong, the red line over the picture 3, if the ILM marking is not correct, then I'll just show you a video also. Then you have the zone 4, how the BMO is being marked. You can see those red dots, that is the Brooks membrane opening dots. And then you have the Garvey-Heath grid. So just look, So the minimum rim width is basically compared for the ages between 20 to 87 years. If somebody is below this or above this, this is not going to be useful for you when you do the scanning. So the Brooks membrane opening MRW analysis chart, what does that 3 lines show in that? One is the green line. The green line is basically meant for, that is the baseline. And if the line comes, there is a black line. That is the line, the actual scanning line. Shows if the thickness of the optic disc is, the diameter of the optic disc is smaller, how it will be shown, I'll just show that. And you can see there is another small gray line, that is the follow-up line. So there are 1 or 3 lines. Totally will be 3 lines if it is follow-up is being done. So we'll just describe that one by one later. This is a small video clip about the Brooks membrane opening minimum rim width. You can see that there is a small area in the red marking I've done here. This is abnormal. So once you see something like this, then you have to just go back and see whether the ILM is being marked properly or not. Here you can see that ILM is not been marked properly. So you just have to go to this area, click this button, and then you can see that it goes to the ILM, proper ILM marking. So click the ILM, and then you can see that there's a round is there. This is the only instrument where you can really adjust your proper ILM marking and also the Brooks membrane opening. all the equipments of the OCT works on the AI principles, but unfortunately in other machines we cannot change anything. This is the only machine where you can do all the changes, so your measurements are very, very accurate. So once you have done the ILM proper marking and you can save and close, immediately what happens is then it will get changed. So you see here, now this arrow mark that the dip has gone off. So this is how you change the ILM and then get a proper BMO MRW markings. So if you have the defects, you can see the black line here. The black line goes up and down, and you can see this is the moderate defect here, and then you can see that the defect of this black line is touching the red zone in almost all the quadrants. So that is a severe defect. And you see here that is a localized defect where only one area, that is inferior nasal and inferior temporal area, has gone down. So with looking at this B-scan map is essential, and you can really look at where exactly is the damage happening. So what is all this, the macro papillae and micro papillae? We are all used to see the big disc and the small discs. So what is the importance? When you see the macro papillae, the whole diameter is so big, and if you see the micro papillae, the diameter is smaller, but if you have the same amount of nerve fiber layer arranged, then imagine with the circle is bigger, it is sparsely there. But if it is smaller circle, then you can see the density of the fiber arrangements. That's why you see here in this B-scan map, the micropapillae, the thickness is going to be much higher. And you see the macropapillae, that the thickness is lower. So it is just lying below the green line of the baseline, but it is within the green line itself. It is not touching the yellow or the red. So this is one thing which you will have to understand. Sometimes when you see this is down, you should not think the patient is having a damage. At the same time, when the micropapilla is arranged here, then you should understand that there is something is going on also. So this is the same thing which I was just trying to discuss, how you can really look at the localized area of damage. And this is the same line which I was just describing. So coming to the Garvey-Heath grid, so what is this? You can see the red. So that means the damage is less than 1% in red, 1 to 5% in yellow, and if it is normal, that is more than 5%, that is in green. So that is easy for us to understand. So just understand this grid. You can see that I just put one sector separately. Shows that minimum rim width is about 298 microns. That means it is, you can see that there is 40%. It is not 40%, it is 40 percentile. So that is important for us to understand. A value of 40 percentile of the normal means it is the 60% of the patients in the age-corrected reference database have thicker MRW values, while 40% have MRW values of this size or thinner. So this is critical for us to understand. When we have the discussion, we can go through that. So just to go back again, this is how you see the printout. This is a normal. You can see the Garvey-Heath, everything is showing green. But all of us have the habit of something seeing in the visual fields the gray scale. But never do that. Always see the B-scan. First you see this map, see the B-scan map, and then only you have to come to the Garvey-Heath grid. Don't jump into the, you can see in this, all these have been marked properly. Then you see the Garvey-Heath, where exactly is the damage happening. So understanding the Hood report, what is this Hood report is all about, is basically looking at the visual fields, correlation of the visual fields. So you have RNFL damage over there, which is been shown in the B-scan map, and of course in the RNFL, and as well as in the Garvey-Heath, that is the MRW. It has to correlate, otherwise it is not going to be proper. If everything is correlating, then you look at these deviation maps, you can see that RNFL change, there is no RNFL there, so the blue is the defective area. And then similarly, when you see the GCL map, again you have an area where there is a defective GCL. So just, we all understand the fields is always the flip. So if you look at this area, you can see that the change is happening over there. That is the 24-2 visual fields. It is compared to the Humphreys. And you see here, this is the GCL map, which is the central zone, central 10 degrees. So it is 10-2. So we can easily correlate in the visual fields here. This is 24-2, you can see the NFL change. And you see the 10-2 here. You can easily understand the GCL, it is much more in the central 10 degrees. So we can easily correlate these defects. So coming to the MRW Garvey Heath progression analysis, if you just click here, there is a button over here, you just click the progression button and then you can get this chart, and then this chart will show, there's one area here to show all the sectors to superior temporal, inferior temporal, nasal, all that. You just have to go click that and then it will show each follow-up, how much is the thickness in these patients. So by this you can understand what is going on for these patients. The thickness, is it the same? Sorry. Is it the same that is happening, or is there a change over a period of time? You can have multiple follow-ups and then you can see what the average thickness it is maintaining. That is a normal thickness. If it is something below, then you can understand, okay, there is a real defect which is happening. So it is easy for us to understand, but the reason why I am emphasizing is that you see in your system is when you have the printout, you cannot have so many printouts to understand how the progression is happening. Because each area you can go click and then see what is happening in each zone. Yeah.
See, if it is visual fields, I know it can go up and down.
Yeah.
That means if you're having spots coming up and down the regression line,
Yeah.
then it indicates that there are outliers. How do you get an outlier?
If you have not marked properly, then you will have the outliers.
As you rightly pointed out, you see an outlier in imaging.
Yes.
You have to revisit your image.
Absolutely. Yes. So we'll have the discussion time, then that time we'll see that. Yeah, that is an important point that which you have raised, though these are all automated things, but each visit we have to do the proper BMO marking and the ILM marking, otherwise you are going to have a problems. So what we were discussing about all this time is looking at the optic nerve head, radial and the circular scan. That is what we were discussing about. So thank you so much for your patient listening, and thank you, Sweta, for the opportunity.